Hi, good morning to all. I know I have been taken a wide long break because I had to settle in a new city with more responsibilities and marriage, and also finally I have taken the time to resume my pathway videos. So I thought I will start with recent advances itself. So this is a topic from Recent Advances 26, and today's topic is soft tissue tumors with epithelioid morphology. So today we will be discussing about the introduction and then few sarcomas as given in recent advances, that is epithelioid sarcoma, clear cell sarcoma of soft tissue, alveolar soft part sarcoma, sclerosing epithelioid fibrosarcoma, ossifying fibromyxoid tumor of soft tissue, epithelioid angiosarcoma, and epithelioid hemangioendothelioma. So, there are numerous soft tissue neoplasms that can exhibit epithelioid morphology. It is a very challenging situation for pathologists, but as we all know, the most common tumors with this morphology is obviously the epithelial cell tumors, that is carcinomas. And then we have to rule out others like lymphoma, melanoma, etc. And then only we have to think about soft tissue tumors because overall they are very rare tumors. So, the common tumors like carcinoma, melanoma, lymphoma, and germ cell tumors are the tumors that you have to think about first. And then, if it is not responding to the treatment, or else you see the IHC markers are negative, then you have to think about soft tissue tumors. So, to distinguish from soft tissue tumors, you will obviously use molecular sequencing studies and IHC, but you should obviously keep in mind that there are overlapping staining properties like cytokeratin, etc., can be positive even for the soft tissue tumors, which makes it more challenging. So, firstly, we will discuss about epithelioid sarcoma. So they are usually multinodular aggregates of epithelioid cells that are surrounded by stromal spindle cells. And they are usually of two types, that is the usual type and the proximal type. And as you can see in the figure, the usual type usually occurs in the upper extremities, especially the hands and fingers, and they can be seen as a single nodular mass or a multinodular mass. So the usual type is usually seen in young adults, especially the males, and they are seen in the dermis and subcutaneous part of the distal upper limb, that is hands and fingers. And then they are usually slow growing solitary mass, or they can be as multiple nodules as seen, and they show central necrosis and they are firm in consistency. And they can metastasize locally to lymph nodes and distally to the lungs. So as we all know, as a dictum, ki sarcomas goes to the hematogenous route and carcinoma spread through the lymphogenous route. Okay, so but there are some sarcomas that can have a predilection to lymph nodes as well. So those you have to remember that epithelioid sarcoma can go to local lymph nodes. Proximal type is usually larger mass and it is usually seen deep-seated and seen in axilla, inguinal region, flanks, pelvis, etc. And they are more aggressive than the epithelioid sarcoma. So histologically, as you can see, there is the nodular aggregate of the epithelioid cells that have abundant eosinophilic granular cytoplasm with vesicular nuclei and prominent nucleoli. And this characteristic of each cell is the same morphology that will be seen in most of the epithelioid morphology that I'm discussing. That is abundant eosinophilic granular cytoplasm, vesicular nuclei, and prominent nucleoli. The other features that distinguish are they are seen as confluent groups, and then they are surrounded by spindloid cells that are fibroblasts. They are spindly stromal cells. And in IHC, you can see they are cytokeratin positive. This is PAN-CK and this is CK5 by 6. And then characteristic thing is they have show loss of INI1. The INI1 protein is a nuclear protein which is retained in all the normal cells. But here in these tumor cells, these epithelioid morphological cells, they show loss of INI1. And that was the usual type which I showed. And here in the proximal type, you can see they are more aggressive with more larger nuclei, and then they can show rhabdoid morphology, that is with abundant cytoplasm and eccentric placed nucleus. So as I said, IHC they show pan-CK and loss of INI1. They can show CD34 as well. So CD34 positivity means you should distinguish it from other vascular tumors also that show CD34 positivity, like pseudomyogenic hemangioendothelium also. They are morphological mimics. But the thing is that they retain INI1. And here in this tumor, we have loss of INI1. So as the morphology, I said they are nests that are surrounded by fibroblasts and spindle cells. So that is a morphology you see in granulomatous lesions. So granuloma, how you will differentiate it? Granulomatous lesions like TB and sarcoidosis, etc., which are non-neoplastic, can also be a DD for these epithelioid sarcoma. And for them, you will use histiocytic markers because the granuloma is formed by epithelioid histiocytes that show CD163, CD68 positive, etc. And the non-keratinizing SCC also looks like this. So SCC cells obviously retain INI1. Then next we come to clear cell sarcoma of soft tissue. So these are malignant tumors that contain clear cells. And why they are clear cells? Because they have glycogen rich vacuoles in the cytoplasm. And then they were before called as malignant melanoma of soft parts. Why? Because they show HMB45, melan A, SOX10, S100 protein, etc. positive. So they were considered before as melanoma only of the soft part. But then later on it was discovered that the etiology is different. These clear cell sarcomas show translocation 1222 and they show EWSR180F1 fusion transcript positive. They are usually seen, which is not seen in malignant melanoma. And then CCSST is seen in 20 to 40 years of age group. They are slow growing mass, which is usually seen in lower limbs, especially in the ankle area as seen in the figure. They arise from tendon sheaths and aponeurosis, and 5-year survival rate is almost 50%. So you can imagine how aggressive or malignant the tumor is. So histologically, they show epithelioid to spindle cells, and then these cells have abundant cytoplasm and they can have a clear glycogen-rich cytoplasm. And then they can show melanin pigment as well. That is why before they were called as melanoma of soft parts. And so these melanin pigment areas show OX10 positivity. So as I said, melanoma markers can be positive, and the distinguishing feature from melanoma is that they show fusion transcript, which is EWSR1 ATF1. So DDs are malignant melanoma, and some other sarcomas like synovial sarcoma and malignant peripheral nerve sheath tumor as well. So in these two things, obviously the melanoma markers will be negative. And then next we come to alveolar soft part sarcoma. So these are seen in 15 to 35 year of age group, more in females. They affect more lower limbs, and in children they might affect mostly head and neck region. They are slow growing painful mass, and they show transcription of X chromosome with 17 chromosome, and they show ASPSCR1 TFE3 fusion transcript. Okay, they show early metastasis to brain and lungs, so their malignant potential is high. And but in children they have comparatively good prognosis because they are smaller and resectable tumors. Surgical resection is the mainstay. Obviously there can also be chemotherapy, radiotherapy you can opt for after surgery if it is not getting resolved, and then you can also use tyrosine kinase inhibitors. So histologically, these show solid sheets of cells that are epithelioid with vesicular nuclei and prominent nucleoli, etc. But they can show pseudoalveolar pattern, which is the characteristic of alveolar soft part sarcoma. The pseudoalveolar pattern is because they show slow degeneration and there is loss of cell cohesiveness. Okay, cell cohesiveness means because of the tight junction, there is cohesion of the cells, that cells stay together. So when the cells are not staying together and they show some signs of degeneration, they looks like a pseudoalveolar pattern. Okay, And then in sometimes in some cases there is so much of solid sheeting that you won't see the pseudo alveolar pattern, and it is much more difficult in diagnosis to differentiate it from other tumors. So they show TFE3 and cathepsin K positivity in IHC, and as I said, the fusion transcript will be positive, this specific one. And the DDs are extraskeletal myxoid chondrosarcoma, which can look like this, the myxoid areas of the chondrosarcoma. But those tumors show EWSR1, NR4A3 fusion transcript. Proximal type of epithelioid sarcoma, as I said before, they show loss of INI1. And other DDs are granular cell tumor that can show S100 and SOX10 positivity. Other remarkable thing which you have to also notice is the metastatic RCC. Renal cell carcinoma is notorious to metastasis to anywhere, okay, even to the soft tissues. So when there is a soft tissue lesion, especially alveolar soft tissue sarcoma, if it is present in the thighs, buttocks region, RCC, if it is metastasizing, other problem is that the fusion transcript which is seen in this tumor is also seen in RCC of a variant which has translocation XP11. So that type of RCC show even this fusion transcript. So how do you differentiate this tumor from RCC is by putting PAX8 IHC. So you should always differentiate it from RCC by putting PAX8 IHC, which will be positive in RCC and negative in ASPS. Nextly, we come to sclerosing epithelioid fibrosarcoma. This is a deep-seated mass which is usually seen in the lower limb. It can be seen in upper limb, trunk, head and neck region as well, mostly in the 40s to 50s age group. They are very aggressive and they show late local recurrence as well and distant metastasized to lungs. They are well circumscribed and lobulated mass. 5-year survival here also is 50%, that is, it is very aggressive, and it can be seen as combined with low-grade fibromyxoid sarcoma. So they are usually said as a hybrid tumor of SCF and LGFMS if you can't differentiate between the two. So histologically, you can see these are round to ovoid cells that are seen with vesicular nuclei, inconspicuous nucleoli, etc. And you can see they are seen in densely hyalinized stroma. Okay, so that is a characteristic. And IHC, they will show MUC for positivity. So IHC, they will show MUC4 as well as EMA, and characteristic CREP3L2 and CREP3L1 fusion or gene rearrangement is seen, which is usually seen with EWSR1 and FUSG. Okay, so that is usual scenario. In abnormal or unusual atypical times, you can also see MUC for negative tumor, and in those the gene rearrangements will be mostly YAP1 or KMT2A gene rearrangement. That means this tumor is very dynamic and pathology is very confusing. So you have to go for morphological features, site and other things. If you have ruled out, then you have to also think that there is an entity of SCF with MUC for negative as well. So differential diagnosis from carcinomas, you should differentiate in carcinoma pan-CKS positive, here it is negative, lymphoma CD45 positive, here negative, melanoma S100 is positive, here negative, and then other DD is sclerosing rhabdomyosarcoma, in which myod1 is positive, but in this tumor it is negative. Other differential diagnosis is ossifying fibromyxoid tumor, which I will be coming again. There also you can see MUC for positivity, but the gene rearrangements and fusion transcripts will be negative in that tumor. So as I said, the next is ossifying fibromyxoid tumor of the soft tissue. So here it has a very diverse histology. It can be benign to malignant as well. So depending on the histology, you think it is benign or the malignant counterpart, and if it is malignant it can show local recurrence and distant metastasis, etc., usually seen in the 50s in the males, and it is a subcutaneous mass, especially in the extremities, that is upper limb and lower limb. They are well circumscribed and see lobulated mass with thick fibrous pseudocapsule, and they can be Like benign histology shows mostly low cellularity, low grade nucleus with less than 2 mitosis per 50 high power field, and then malignant histology is mostly higher cellularity, higher irregular high grade nucleus with more mitosis, etc. So histologically you can see within this five there is thick fibrous pseudocapsule, okay, and in that itself you can see some prominent mature bony areas as well inside the capsule. And then they show nests and cords of cells that are round to oval, and there is a fibromyxoid stroma. Sometimes the fibromyxoid stroma is very abundant. And IHC shows PHF1 gene rearrangements usually, and in which PHF1 EP400 is the most common fusion transcript. And as I said, MUC4 will be positive in this tumor. So DDs are cutaneous adnexal tumors in which SOX and epithelial markers will be positive. Here it is negative. And other, as I said, sclerosing epithelioid, fibrosarcoma, and low-grade fibromyxoid sarcoma in which those transcripts like CREP3, L2, etc. will be positive. Here it will be negative. Paraosteal osteosarcoma can share same gene transcript. If you have read recent advances 26, you can see there are so many fusion transcripts or gene rearrangements that can be seen with ossifying fibromyxoid tumor. And in that, some transcripts are common with even paraosteal osteosarcoma, which can be difficult to differentiate. Second, lastly, we come to epithelioid angiosarcoma, which you see as the name suggests is a vascular tumor angiosarcoma. So you will see vascular endothelial cells with epithelioid morphology. So they are usually seen in the seventh decade, that is in the 60s. It is a deep-seated mass in the extremities and it is seen intramuscularly. They can metastasize early to lungs and it can be very lethal in a short period. And as you can see, it has a very high grade morphology, very lethal, malignant, and it shows scant eosinophilic cytoplasm with a very large nucleus which is having irregular nuclear membrane, and it can be hyperchromatic or it can be with vesicular and prominent nucleoli and high mitosis, etc. One characteristic feature is that they show vasoformative appearance, that is, they show anastomosing vascular spaces. You can see the vascular spaces usually in hemangioma, that is capillary and cavernous hemangioma. You will see vascular spaces, but they are usually lined by plumb endothelial cells with bland looking nuclei or with flattened cells. But here you can see these are lined by very malignant cells with irregular nuclei and high grade nucleus. So IHC wise, they show vascular tumor markers like CD31, 34, vimentin factor 7, etc. And even pan-CK will be positive. So it can be difficult to distinguish it from epithelioid hemangioma. But hemangioma is a benign entity and this is a malignant one. And epithelioid hemangioendothelioma, which I will be coming to, which will usually have inconspicuous nuclei, less necrosis, lower mitosis. It is lesser malignant than epithelioid angiosarcoma and it has WWTR1 CAMTA1 fusion transcript positive. So epithelioid hemangioendothelium, the last sarcoma that you will be, last soft tissue tumor that we will be discussing today. It is a vascular tumor with epithelioid morphology. It is less aggressive than the previous one which I discussed, that is epithelioid angiosarcoma. They're usually seen in adults within or around the vessels, and it can also be seen in lungs, liver, bone. They can be single to multicentric mass and they are painful usually. And low risk group may it comes as less than 3 centimeter in the diameter, less than 3 mitosis per 10 high power field. So if it is more than 3 centimeter and more than 3 mitosis per 10 high power field, it goes to high risk group. And they can also show intracellular cytoplasmic vacuolations with RBCs, like cytoplasmic vacuoles with RBCs can be seen in epithelioid hemangioendothelioma. As you can see here, vacuolations with the RBCs, that is inside the cell cytoplasm itself. They are usually seen as nests and cords of epithelioid cells with round nuclear vesicular chromatin, etc. And IHC wise, they show CAM-TA positivity. The CAM-TA1 positivity, they show fusion retranscript, that is WWTR1 and CAM-TA1. And then they show as angiosarcoma, like that they also show CD31, 34, cytokeratin, etc. positive. So their DDs are, as I discussed, epithelioid hemangioma and epithelioid angiosarcoma. So we'll just summarize the things which we studied today. We studied 7 tumors. In that, epithelioid sarcoma are usually seen in young adults in the upper extremities. They show confluent epithelioid nodules surrounded by spindle cells which can mimic like granuloma or maybe non-keratinizing squamous cell carcinoma, and characteristically they have loss of INI1 in IHC. Next is clear cell sarcoma of the soft tissue, usually seen in 20 to 40 years of age, especially in the lower limbs, that is the ankle region, and they show glycogen rich clear cells in microscopy, and their most common DD is malignant melanoma because they show HMB45, melanase, oxtens, S100, etc. But they are differentiated by the fusion transcript, that is EWSR1 ATF1. Then there is alveolar soft part sarcoma, which is usually seen in 15 to 35 years of age and seen in lower limb, especially thighs and buttocks. And they show pseudo-alveolar pattern, as the name suggests. And they should be mainly differentiated from RCC, which can also show the same fusion transcript of ASPSCR1 TFE3, and RCC will be PAC site positive. Here it will be negative. They are also differentiated from extraskeletal myxoid chondrosarcoma by this fusion transcript. Then you have sclerosing epithelioid fibrosarcoma, which is usually seen in 45 years and lower extremities that have dense hyalinized stroma, and they show MUC4 positive, and they show CREP3L2 and CREP3L1 fusion transcript with EWSR1 and FUSG. They are usually differentiated from rhabdomyosarcoma by MyoD1 and OFMT by the fusion transcript. So what is OFMT is ossifying fibromyxoid tumor, usually seen in the 50s. In the extremities, they show thick fibrous pseudocapsule, and they have PHF1 gene rearrangement, and they are distinguished from SEF and LGFMS. And then next is epithelioid angiosarcoma, usually seen in the 7th decade. In the extremities, they show characteristic anastomosing vascular spaces. They show cytokeratin CD31, 34 positivity, etc. And the DD is epithelioid hemangioma and epithelioid hemangioendothelioma. So the last one, that is epithelioid hemangioendothelioma. They are usually seen in adults, can be benign, malignant, which is seen in the soft tissues as well as in liver, lungs, pleura, etc. They are seen as nests and cords of epithelioid cells, and they show characteristic CAM-TA1 positivity, and they should be differentiated from epithelioid angiosarcoma and epithelioid hemangioma, etc. So we come to the end of this topic, and this is a topic which I took from Recent Advances 26th edition. And I also take this opportunity to thank respected Kyle T. Perry and Anna Marija M. Perry, who has contributed this wonderful article in the Recent Advances. Thank you.